and 82-year-old Harold Bishop has been blue lighted to hospital after being found on the floor by his daughter. The SHO was kind of clocked in, but as usual, not really done any of the relevant paperwork. So it's up to you guys to do all the relevant bits and pieces. So these are his details, and we want you to write about his basic medication, which will come up in a second.
Okay, so he's got a background of insulin-dependent diabetes, he's got hypertension, mild asthma, recurrent UTIs, and he had a heart attack about 5 years ago. So these are his regular medications. So if you could write him up for all of these and include allergies and any other medications you think he might need during his stay.
Are these details?
What's coming to you? You just write this up. Yeah. Yeah. I need to write those.
And then cancel it out as we go.
Yeah.
Is it 27 today?
That's right. Yeah. It's not, I'm thinking it does finish with that night. Yeah, so you
Does it say you have to admit anything? Does she say you have to admit anything? Do we have to admit anything? Or just write them up?
Yeah, no, you can hear a few breaths at the bottom left.
That goes in the inside.
Hey guys, you nearly done? One minute? So you ready? Ready? Yeah. Okay. So we're getting the right presentation. We're getting it sent to us now, so it's fine. But regular medications wise, all that you need to be careful is you'll often get it sent over via the GP, so you just need to be careful of dosing. So sometimes they might write 30 milligrams, but then write 2 tablets. So just make sure that you put the correct dose. But here we've just made it quite simple for you. Is there anything that you think extra that they might need during their hospital stay that you can write on the PRN side? Yeah. Paracetamol, anything else?
community prophylaxis?
Yep, what would you give them?
What would you give them? Bearing in
It's not
mind.
a trick question,
Yeah.
whatever. Say whatever. What's strength?
That's for enoxaparin. So for tinzaparin.
4,500.
Yeah. Okay. But in this gentleman, regarding his probably because of his age, we need to get his renal function as well. We probably would give enoxaparin in this gentleman, but we need to get his renal function back to the side whether it be 40 or 20 milligrams. So we just need to wait for that to come back. So we can write that up.
Sorry, Sandra, what is that? 20 milligrams of
So it's-
enoxaparin, is that like a standard dose?
It's 20 or 40 normally. No, for people with good renal function, so if their creatinine or EGFR is greater than 30, you give 40 milligrams. If it's less than, you give 20.
Okay, thanks. That's all right. It's always going to be on the trust guidelines, so you don't have to learn it.
And there's loads of seniors who still don't know how to do it, so don't worry. It's fine. Is there anything else you can think of, maybe if they feel sick, that you could write up?
Antiemetic.
Yeah. Okay. Do you know your doses? What sort of doses exactly would you give?
50 milligrams 3 times a day.
Yeah, well done, that's good.
Okay, what happened?
And you'd give 50 milligrams a maximum TDS.
That's like
Yeah. Okay.
Just the lowest one that you can do.
Okay, does anyone have any questions about that? Do you feel comfortable writing up drug charts? If you've got any questions, please just ask, because we will have asked it last year.
The main thing is anything you're not sure about, don't write it up until you've either checked with a senior or in the BNF. That's more than okay. Things like trimethoprim and any antibiotics, you have to have indication and duration, even if they've come in on them from the GP. And that's really important, especially in leads, like they're really cracking down on that. And then, yeah, bear in mind, like Sonia said, like renal function and anything like that.
And obviously allergies, which you will obviously be jumped into since third year, but make sure you've got the correct allergy and you know the reaction as well.
You know if it's once a day, or
Yeah.
how do you know whether it's in the morning or on a night that they take it?
Okay, so you'll get to know like some of the medications. So the statins, for instance, you normally give at night. Stuff for blood pressure you normally give in the morning. You will get to know. If in doubt, ask, obviously. But also you can look it up in the BNF. It'll tell you when's the best time to give it. Or if in doubt, ask the patient, because they don't really take the meds. So
I think that
When you write them up for the insulin, do you have to put a box on the drug chart to say
Yeah.
the BM?
Yeah.
So they can't, and then do you have to put in?
no, on the actual drug chart, we have the pictures of these which are coming. But on the actual drug chart, you need to write insulin, and then you need to write C insulin chart. So you don't need to write anything else on your drug chart like this. You need to write insulin up on a separate drug chart. But you do need to make sure you've written insulin C separate drug chart. Is that all right? And then the BMs are recorded on a separate.
Would you just write that on the front chart?
What's that, sorry?
About to see the stuff.
You need to write it like you write up another drug. So, like underneath drug 2, you just write insulin in the yellow box, and then just write a big letter C attached chart.
And antihypertensives, do you not give those at night?
No, you normally give them in the morning. Antihypertensive. Okay. Okay. So you have examined Mr. Bishop now, and you've noticed that he looks very dry and dehydrated. He's not been eating for a few days. You're now asked to take blood to put a cannula in. So using the correct blood form, please can you write him up for full blood count using his clotting and a CRP and label the form correctly. We'll give you a couple of minutes to do that.
Sorry. Oh, right, yeah.
15 years.
What was the indication?
He's just come in and he's doing an operation, so it's kind of like the set of bloods that they take before an operation anyway, and the nurses are just a bit like, oh, has that been drinking, has that been eating? It's just kind of like baseline tests, really.
Okay. Is that right? Just right there, like pre-op?
Pre-op, yeah, you can mark pre-op, and then afterwards post-op, they don't really care.
Okay.
It's things like microbiology and stuff like that, you have to be more specific about.
You all okay with that?
Which side of the CRP needs to go on in the boxes?
Okay, so the CRP needs to go to the biochemistry bit, and the clotting needs to go to the haematology bit. So the only things that really go on the haematology side are obviously full blood count, clotting, haematinics. They would all go on that side. The rest of it is put on the biochemistry side. They normally will process it if you put it on the wrong side, but you look like a bit of an idiot. But they will process it, so it's fine. Is that all alright? Have you got any questions about blood forms?
Can you just say that again?
Yeah, of course. So on the haematology side, so on this smaller side, you need to put, the only things that really go there are full blood count, clotting, so if you needed somebody with INR or warfarin, and haematinics, you can put on that side as well. And then on the biochemistry side, you put CRP. If you needed LFTs, glucose and calcium all there already. TFTs, everything like that would go on the biochemistry side.
It's just making sure you fill in all the details, really aim on it. Again, they'll send it back to you, they won't process it, and they won't always tell you as well. So if you've got a patient that's really to push or bloods that are needed urgently, just make sure everything is labelled.
Is that alright? Any questions?
Do you write urgent, please override on everything?
You can do, but this patient's new, so you can just write urgent, you don't need to write override, because it wouldn't have been done already. In the Leeds Trust, they've got a new rule, I don't know how many of you are staying here, you shouldn't really be repeating blood tests within 24 hours, so if they're urgently needed, you need to write override on every form. That's when you're in F1, you won't need that in your scheme.
Sorry, where do you write override?
You can write it anywhere on the floor, just wherever you can fit it. In the top right, left-hand corner, they've already rewrapped it there.
Okay, so you get these blood results back. What do you think this is? Pardon?
AKI.
Yeah, it could be. What else could it be? It could be, yeah. What's that? Yeah. Your SHO is busy, sleeping, and it's up to you to again sort out this guy. What would your plan be if you got these results back?
Get some fluid going.
Yeah.
Okay.
And what else would you want to do? Pardon? Yeah. Excellent. Yeah.
Okay, so you've said fluid, so can you write up some fluid for this gentleman on a fluid chart, please, and the regime that you give?
I don't know, I just think it's too alternative. You know, like,
Hey, you guys done? Ready? Okay. What's your plans for fluids then? What are you going to give this guy? Doesn't matter if you're wrong, just have a go. Anyone?
Yeah, how fast?
Okay, yeah, how fast are you going to give them?
8 hours.
Good. Okay, are you going to write them up for, if we wanted it for 24 hours, what would be your regime? Yeah, so what would be the regime for 24?
And then dextrose and dextrose.
Yeah, no, that's good, that's good. We were just both saying, we were quite daunted by fluids, definitely before finals and before we started F1. Everyone's got different rules, but we go with the rule of thumb of 2 sweet, 1 salt. So that's right to say, that's really good. So 1 bag of 0.9% saline and 2 of 5% dextrose, so that's really good. We don't have a potassium yet, so we're not going to add anything. You normally give 20 millimoles with each bag, but we don't know what it is yet, so we'll wait till potassium.
Sorry, how long are you giving the first bag of?
We're going to give, for this guy, it's fine to give it over 8 hours because he hasn't got any problems like with heart failure or anything like that. You need to be careful in patients who are a bit older. You might have to give it a bit slower. So if you did have heart failure, you'd probably give it 10 to 12 hourly. And you may have to give it plus or minus 3 hours, but probably 12 hourly.
Thank you. Good.
So you thought about like the acute management of this patient, so giving them fluids and resending the bloods, which is really good. So now, what else do you need to think about in a patient that you're thinking could have acute kidney injury? What else would you want to look at? Yeah, urine outflow. Anything maybe to do with more what you've already written?
So the drug chart.
Yeah, excellent.
Okay.
So if you want to cross off any drugs, if there is any that you think might be contributing to his recent decline in kidney function.
Cross doses, I've got the mid doses. Do you want just to cross drugs off at mid doses?
Yeah, cross. Well, whatever you think.
Inside the kitchen to find
Yeah,
oh, right.
Just sorry.
Oh, okay. Alright.
Oh, so you don't cross.
Okay, so sit and a box. Do we write proper switch or do we set Oh, okay. Okay.
and then put a box that's in
So we start off on this day, so let's say the 28th, we just do it on the next day.
Alright guys, so which ones do you think needs to be crossed off? Yeah?
Review, yeah.
Which
Cool,
are the
thank
ones?
you.
Yeah?
Oh,
Yeah? Okay, so this is definitely something that could come up in the OSCE. You might have to cross out drugs. It might not be for AKI, but I think we had one last year, didn't we? I think a gentleman came in with a GI bleed, and we had to cross off or write up his medications and not write up the ones we didn't want him to be on. So definitely try and be aware for your OSCE, definitely for AKI. If anyone's coming with an acute bleed. So any other scenarios?
They're the two
I think they're the two main ones that could come up. So definitely be familiar. These are, there's loads of acronyms which we couldn't remember. There was canal, we remembered that one, and there was diamonds, I think, for nephrotoxic drugs. But these are the main ones that we kind of use every day and we learn for the OSCE. So if you want to jot those down.
Do you have to cross the oxygen off, or do you just give it like half dose?
You'd give it at the 20
milligram dose,
yes,
yeah.
you would reduce it. The thing with orthopedics, that's different to elderly. Elderly, they're really good and they give an oxyparin standard. In orthopedics, we don't. We just give tins 4,500, and it's not always changed to the appropriate dose or regime. Yeah, which isn't good.
In the clinical setting, because he's in AKI, but it's not that florid, is it? So
No.
would you give him fluids and then see how he went before crossing off all the drugs, or would you just get rid of all the nephrotoxins straight away?
I normally cross them off,
Yeah.
and then they're normally reviewed anyway the next day or on the same day by the consultant, and they can make a decision. But you're better off, especially if he's going to surgery, to cross them off.
When you say cross them off, do you mean like cross out like the next day's doses?
You can either do that or you can cross them off
for the
completely
chance?
because you want his kidney function to improve before you give them. So you can just six them for a few days, or you can cross them off.
You'd be like, you wouldn't be told off either way. It's like these.
And what was wrong with it, sorry? What was wrong with the trimethoprim?
Antibiotics are nephrotoxic, so you need to cross those off. And he's having it for prophylactic use, so it's not absolutely desperate that he's on it, so that's fine to be crossed off.
In some scenarios, we've said, like, do you permanently want to stop them, or which ones would you review? Is there any, have you got any advice on that, or do you just literally, can you standard answer just be depending on?
Yeah, there's no exact answers in medicine, so you saying that is more than okay. It's worse than you. It would be worse if you were like, oh no, I'd stop everything, or I'd carry everything on if you don't know really what you're talking about. So that's fine, don't worry. And if they badge you for a direct answer, they're just being an idiot. So don't worry.
Is there like a safe antibiotic you can use in AKI if they're septic?
Well, yeah, if they're septic, then you'll have to use an antibiotic anyway.
But
So
is
you
there like a
do-
known safe one that
Thanks probably safe. Like you'd avoid things like gentamicin, and you'd probably you'd have to speak to like microbiology and then direct you to like the more weird and wonderful ones like meropenem and tigeplane and things like that. Like you wouldn't necessarily have heard about. Well, I certainly hadn't heard about those when I was a fifth year.
You can just ring microbiology when you're working.
And they're normally okay, and they'd probably be alright in this kind of scenario.
When you were talking about cutting down the enoxaparin dose, is that because that is nephrotoxic as well? You said cut it from 40 to...
Yeah, so remember earlier we were just saying that they've got rubbish renal function.
Yeah.
So you can cut it from 40 to 20 if you didn't know the renal function before they came in.
And is enoxaparin less nephrotoxic than tinzaparin? So would you switch them?
Yeah, apparently so. So in elderly, that's why we normally use enoxaparin. It is meant to be less.
Okay.
So
So in this OSCE style scenario, we should probably reduce the enoxaparin, or switching from tins to enoxaparin,
Yeah.
reduce that. Okay.
If you did that, I think they'd be
really impressed. It's unlikely that you'll get that in the OSCE. So that's good that you, yeah, don't worry about it.
We'll be able to work at the end of the day.
as long as you like consider it or mention it, then you know that's fine.
Okay.
Okay, so as is pre-op, I don't know if you've got have you got the Part C insulin chart?
They can be there. Yeah, I've got it. This one is fine.
Yeah, I know.
You can't see the new one.
Yeah, it's yeah, he didn't want it. I didn't write it down.
Everyone's getting all right writing the insulin? Do you want us just to go through it, or do you want a few more minutes? Go through it. Go through it? Yeah. Okay, so do you all understand the Part C insulin chart? Do you understand how it works? Okay, so what, for Part 1, what did you circle? What's he on? Low, medium or high?
Medium.
Okay, so how many units is he on a day? 50. Yeah, spot on. So you just need to, again, it's just, all the paperwork is quite simple. You just need to make sure you fill in all the parts and the job will get done. So as long as you've written the regime at the top, the procedure he's going for, and the medium part, then if you all written it up inside on that bit as well. Chart C you need.
What's the difference?
Okay.
What's the difference between the chart and this one? We've got A.
A's like A's your regular, like subcut, regular subcut. So that's the one you'd have like on the ward if they were just on inches. You need to write that up for this patient as well.
Right.
And then we rarely use B. We hardly ever use B. C is for surgery, the pre.
And what was the medium that you just spoke about?
Okay, so on the front of the drug chart, we did have these pictures. You need to go to Part 1, need to work out how many units he's on. So he's on 50 units altogether in a day. Okay, so then you look here and it says 40 to 80, between 40 and 80, medium insulin regime, and then you circle here. Okay, so then you literally just write that out on the inside of the chart. I can pass you these around and see how they're done. That's an example one if you want to pass it around. Wait.
So you'll have to like ignore that
Permanent exposure, 8 morning contract.
Okay, so we've got the correct thing now. So on here, Alice, this is what we were on about. So here, you circle the median bit there, and you literally write those numbers on the inside of the chart up there. Is that alright?
Can you show us the close-up again? Because we don't have one to do that.
So that one, you circle the median. Because if you look on, hold on, with the hand, let's pass it around. So if you look there, you need to look at what the number of units are. So that one says 40 to 80, so he's on 50 units, it's between 40 and 80. So you circle where it says medium there, you circle medium, and then that's what you write on the inside of the chart, just literally write the numbers out. Is that right?
Yes.
Right, so, is everyone alright with that, or do you want us to go through anything else with that?
Where would you use B?
I've never used part B. I don't know. You hardly ever use them.
Sonia, do you know that on the inside cover, do you need to put anything down?
No, it's fine. I know the nurses will always be.
Alright guys, so you, is that alright? You've got any more questions about that? It'll be the nurses that do it, so you don't need to worry about it, but I think they normally do it hourly, and that's why the sliding scale is good, because they can change the amount of insulin the patient's getting. They'll come and tell you if there's a problem, so you don't need to worry about it, which is good.
Okay, so these are the blood results after you've retaken them. What is it? What are you going to do?
Still AKI and dehydration, but what else?
Do an ECG.
Okay. What else are you going to do? Well, what's it showing first? Yeah, okay, so you say you can do an ECG, what else would you do?
Salvage on there.
Yeah? Okay, well, we want you to write it up, so whatever you think you do, can you write it up on the relevant charts? We'll go through it.
Yeah, just totally fine. So let's start with them on 5 milligrams.
No, but I do like see if what do you call it?
With them insulin, so when you
Oh, which shot? I think you put it in. I think you put it in. So I'm happy to 10 minutes.
You nearly ready, or do you need a couple more minutes? Okay, so what do you guys think you do? We'll show you the slide of the charts, but what's the first thing you're going to do before you treat at all? What's the first thing you do?
alright.
Yeah, examine the patient. Good. No forget the patient. Okay, and then what would you do? ECG, okay, and what have you written up on your chart?
Insulin.
Okay, yeah, how much are you giving, and where have you written it up?
On the fluid chart, 10
Okay.
units with 50 mils of 50% dextrose.
Good. Okay, what else do you need to give?
I'd rather wait for my ECG to come back before I could give it. Oh, should I just give some NEDs too?
Yeah.
Salbutamol NEDs, 5 milligrams.
Yes. Is there anything else?
Well, I've been told not to give calcium gluconate unless it's greater than 6.5 or it's greater than 6 with ECG changes.
Okay, that's good. Okay, so yeah.
How long have you did it for?
Okay, so that's what the front of the drug chart should look like if you're treating someone with hyperkalemia. You need to put it on the front because you want to give it stats, you want to give it straight away, you want the nurses to know that you need to give it. In someone with hyperkalemia, hand it to the nurse, don't just leave it by the bedside because they won't do it. So make sure it's written on the front and they know it's urgent.
Is the calcium gluconate slower?
It's over 10 minutes.
Yes, a minute, I think.
It's slightly irritant, so it's over 10
Yeah,
minutes.
it's irritant. So it's 10 to 30 minutes I think they give it. The nurse don't.
Would you put that on the drug chart or would you put it on the fluid chart?
You put these two on the drug chart,
Okay.
and then those two on the fluid chart.
That's only 15 minutes.
Thank you.
So do you need to
Well, where would
write
you
down
write
extra
that?
saline, or was that the thing that we'd originally put
That's the
down?
original saline,
Oh,
yeah.
If this had worked, it would have been higher.
Is there any concern with the fact that this guy is already a diabetic patient, so does it influence it kind of?
Thank you.
Well, you're giving dextrose to compensate for it. In this case, it's an emergency, so you just need to sort that out. You're giving dextrose to compensate for any extra insulin. You can check the BMs afterwards and treat accordingly, so that's fine.
This is the thing that if it was going to kind of kill it before,
Any problem?
yes.
Blood sugars.
Okay, so you've successfully treated this hyperkalemia. And then you get a beep from the nurse about 5 in the morning, and they're telling you that the patient has a Muse of 5 and that you have to come now. So you ask them what the Muse of 5 is, and these are the bits that he's using for. So he's got a BP of systolic of 88/40, and this is a fella that was hypertensive before he came in. His heart rate's 100, so it's only just scoring a point. His urine output is absolutely rubbish, so he's getting 2 Muse points for that. His stats are 98%, which is fine. He's on 4 litres by nasal cannula, so he gets 1 point for that. And his rests were okay, they're about 18, and his temperature is 38.4. So what are you going to do when you go get this bleep? Yeah, excellent. So A, he's talking to you, so that's okay. B, there's a few creps on his right face. You can kind of convince yourself of that. C, BP's dropping, again, he was hypertensive. His GCSE for D is 15 at 15, pupils equal and reactive, and E, his temperature is 38.4, everything else isn't significant. So what's your immediate action then, once you know you've done your ABCD assessment? What are you going to do then? Yep. What would you give? Yeah. There's no like hard or fast rule in the sense this guy's like a quite big fella, so you could give him 500 mils, no heart problem, and it would be fine. If you were a bit worried, you could give 250 ml boluses and then just recheck in between. If he was a little frail old lady, then obviously you just go 250 Volplex. What else are you going to do? BP's come up now to about 110 systolic.
What other investigations does he need?
Blood cultures.
Yeah, so what's involved in the septic screen?
Blood cultures.
Yeah.
An ABG with high flow oxygen.
Yeah.
Antibiotics, broad spectrum antibiotics.
Yeah, anything else?
Urine culture.
Yeah, good. Very good. Okay, so can you please now fill in the relevant form for blood cultures, please, if you've got them in front of you, hopefully.
And chest X-ray as well.
I think it is give 3, take 3.
Yeah, you've got to do something before, yeah. If you want, I'm okay.
You ring the person call.
No, you just fax it off to like A&E. But you can ring X-ray and just say, look, just set down this request. Please can you make sure they come up as soon as you can.
Okay, so in the inpatient time, you just take portable and they just come.
Yeah.
I've got my batteries. I got a truth boxes on them.
Okay, you all finished?
So what sort of things have people written in like the box for the chest x-ray? What would you think would be important things to let radiology know? Yep. Yeah, you'd get away with that, to be honest.
But you need to let them know the patient's age, just a little bit about why they came in, and then exactly what you just said, that's fine. Make sure you say it's urgent, and probably in his case get a portable one like you said. And then you need to ring down if it's portable as well, if it's urgent, just to say, please can you come up as soon as you can, it's important. So just call down. And did you have blood culture forms? No. Okay, we'll send them around. This is what you should be writing.
On the examination, you have to provide high risk.
Okay, so you have to fill in all the boxes. If they're infection risk, if they're in a side, you write high risk. If they're an open bay, just low risk. Yes.
Septic screen, say what your findings were. Right, so you've sent off all of that stuff. He's now sat up happily eating biscuits. It's fine. So you finish your night shift. You've gone home, trying to sleep. Patient's been started on oral antibiotics for his chest infection, and he's now got news about 1. He can go home happy. So Mr. Lim performs his operation, gives him half new hip, and he's recovering well. Your colleagues took post-op bloods, and they've handed over to you to chase them as part of the night team. So when you get onto the ward, you get a phone call from the lab saying that his HB is 6.7, and it's previously 11. Now remember back to last night. I know that's not good. What are you going to do?
This is something that came up in our OSCE last year as well. So.
Go and assess the patient.
Yeah. What else would you do? What are you looking for when you're assessing him? Does it look like breathless? Yeah. Yeah. Does it look like obviously being wet? Yeah. That's good. Okay. And what else would you do? Once you've assessed him? He's got a hemoglobin of 6.7. Yeah. Yeah. Okay. So can you, for the purpose of this, you haven't done a group and save, even though you would have filled it off. So can you fill in the correct paperwork for a group and save cross match, and can you write him up for 2 units of blood? This was station last year. Okay, you ready? Okay, so you need to consent the patient as well for a blood transfusion. Have you all done consent? Are you comfortable with consenting? Yeah?
Well, we're told to. Oh,
no, go on. You sure?
What about the whole consenting?
Okay.
You can consent for blood.
That's why.
Yeah, you're allowed to now want to consent for blood. It's fine. Are you alright with consenting? Sure. Okay, so this is what your blood form should look like.
Are you not ordering a cross match blood, or is it?
Well, you can bring the.
Okay.
What we should have said was he's had a unit of blood in the op, so that makes his group and save not valid.
Okay.
So you had to repeat the group and save. So if you just take group and save, and then once that's set down, and then you've got time to consent the patient, write everything up. You're in blood bank and be like, can I have 2 units for Harold Bishop? And they'll be like, yeah, that's fine.
It's really quick.
Even the nurses can ring up.
Okay.
It has to be a doctor if it's overnight, and they're a bit funny about it, but.
Sorry, Eva, just to go back. So if you do a group and save and you take someone to theatre, and they have blood during theatre, you have to do another group and save.
If they have any blood at all at any point, you have to repeat the group and save, regardless if they've gone to theatre.
In case they get antibodies or.
Yeah.
But if you send it for cross match, they group it there and then, don't they? And then send you blood straight away.
Yeah.
So wouldn't that just save you a phone call if you just wrote cross match?
So after next to red cells, you need to put 2 units, and that would, then you have to bring them.
Yeah. But either will do it the same. I suppose it would be a bit quicker.
Would we? Oh no, it's fine. You know, special blood product requirements. Is that where you'd write your fresh frozen plasma? If you needed it.
If you needed it.
Yes. Okay.
Okay. And that's what the prescription should look like. Is that alright?
How do you know this 4 units?
Every unit red cells do the they only
get people paid. So 6.7 in 2 days. So blood group and stuff like that, you just want to the the 2 units of stuff. Yeah, you want it to
ready? Right. So the blood cultures that you took, you've just changed the preliminary reports, and it's come back as Staphylococcus aureus positive, and its weight is 70 kilograms. Now, when they come into hospital, they do like swabs of nose, groin, axilla, and this fellow was in hospital recently and was MRSA positive, making him a high-risk group. So you've spoken to Micro, and they've recommended just start him on Vancomycin. So if you've got a Vancomycin chart, if you write him up to that.
No, I don't have that. I didn't have that.
Sorry, to go back, you know on the piece of transfusion prescription chart, the first column says patient ID check. Do people have to sign it, or
the nurses do that?
So you don't do that?
We've only got
Okay, well, okay, so we're passing around the bank chart what you need to do, but basically the equation for creatinine clearance is on the back of the Vancomycin chart. That's the bit you need to focus on. So for the initial dose, you need their weight, which is 70 kilos. So on the front of the chart, it'll say the weight and the loading dose you need to give. So for 70, I think it's 1.5 grams you give. So that's quite self-explanatory. And then on the back, you work out the creatinine clearance using the equation. And then once you've done that, you can work out in table 2 the maintenance dose you need to give. So it's coming around now, you can see.
Sorry, do you have another one of them? Do you have any more?
Have you got any more? No.
I'll send it. Yeah, okay.
Do you think we can get this in our OSCE?
It came up in our practice OSCE at Pinderfield. That's the only reason we included it. You could potentially.
You know the transfusion one, did you have to consent them and then do it?
I don't think we had to take blood from an arm and then write up the blood correctly and then just prescribe it. I don't think we had to.
That would be like the world's biggest station.
Yeah,
I think that's still of that.
It'd probably be 2-part stations.
You do need to know how to prescribe Vancomycin as an appointment. That is one of the jobs.
Yeah, I'm pretty sure I got asked to do it my first day on vascular and I had no idea, so probably best to know.
Can you go to the reception actually? Sorry to repeat.
Yeah, okay, no, it's absolutely fine. Okay, so for Vancomycin, what you need to do is you need to know the patient's weight first of all. So this patient's 70 kilograms. So if you look at table 1, it should say something about weights. And then you literally just circle that and give the relevant dose, and it'll tell you how much volume of fluid to give it and everything. You just need to write that up. And then you need to turn to the back of the chart and look at the creatinine clearance. There should be an equation. It's coming round now.
Yeah.
And then you just write it down.
Before and then
Senior messages.
Could you write that?
Right, so
Where would you write that?
move on. The chart will be carrying on going back. So, despite your best efforts, Mr. Bishop unfortunately passes away. Rest in peace. Luckily, he did have a DNAR in place, so you didn't have to do anything about it. So you've been rang up by a lady in bereavement who says it's the most important thing ever, get this death certificate done. It needs to be done ASAP. She's a very busy lady. So the key things you need to do when doing a death certificate is you need to speak to the consultant in charge of the patient, and they need to agree the cause of death, like the 1A, the 1B, and the 2, and all the rest of it. And you've got a form at least that you have to fill out to say that you've done that. For your OSCE, you don't obviously have that luxury, so you have to come up with it for yourself. So, what we want you to do is just have a think about what you think the 1A means, and 2 could be this man. Do you all know what the parts mean? Have you seen death certificates before? Okay, so do you guys know what all the parts mean? What's 1A? Direct progress. Yeah, 1B? And C? Okay, and then 2? Okay, so in this gentleman, if he had a heart attack, what would be the kind of relevant parts? If he died of a heart attack, so that would be 1A. What would be 1B in this gentleman? Yeah, hypertension. Yeah, okay. And anything in 1C? No. Okay, and part 2? You'd have to, because obviously it's come in with a fractured neck and femur, so you're going to have to put that on 2. But if you put osteoporotic, you're okay, like you're covered. So you just need to put osteoporotic, fractured neck and femur, and then say that they had an operation as well. In this case, would you need to get the coroner involved or not? Is that yes? No or yes? About 48 hours.
You die on the table.
What did you say, sorry?
Do you have to inform the coroner because they have an operation, like an intervention?
Yeah. Well, normally you don't ring the coroner themselves. You ring the coroner's office and you speak to the officer, and then they normally bat you away. And it's only more serious things that they'll speak to the coroner, and then the coroner will get in touch with you. I've never had that happen.
So is that a yes? You have an operation?
You speak to the coroner's office. Yeah, you have to speak to them, and then they'll just say if you put osteoporotic fracture and all the rest of it, then that's fine. But you would have to document that you'd spoken to them, just to kind of cover your back more than anything else.
And this guy, what was the actual cause of his death? What happened to him?
He had an MI.
Yeah.
If someone's got septicemia, is that cause of death? Is that 1B?
I've got a list. I went to bereavement and they gave me a list of things that you can put. You'd have to put a specific type of sepsis.
1A?
Yeah, in 1A you can put chest infection. Yeah, you can put old age in 1A as long as you put nothing else, and I think they have to be over 85, 90 or something.
But I think you can't put the failures down, like you can't put renal failure.
So could you put like Staph aureus septicemia 1A or maybe the chest infections because that's the primary location?
Yeah. Yeah.
But didn't he die from like a bacteremia, like a septic infection, wasn't it? So then did that.
You gave him that to he just had a random heart attack. He's a very unlucky guy.
Dave's last time was
Have you got any questions about that? This again came up in our OSCE. You were given all the relevant information, but you weren't obviously able to discuss it with anyone, which is a bit inconvenient.
Did you say that you have to report this to the coroner or no?
You have to bring coroner's office.
Okay.
And then they decide whether they need to further investigate it or not, but you need to definitely get in touch with the coroner.
Just because of the fact that he's had an operation?
Yeah.
Yes.
Okay.
Yeah.
You know the code section where you have to circle, it's like a number, it's just
Like
like
one,
2
two,
C.
Yeah.
What's the sort of normal one that
So
is
normally
most of the time?
you'd circle like 3, and that's like post-mortem not performed, and then I think you'd either say you'd examine the patient or another medical practitioner would examine them. I think that's B or A or something like that. So normally 3 and whatever. And you have to, like, when you sign it, you have to make sure you put, like, who you are, like, say, an LGI, your GMC certificate, and the consultant's name has to go in it as well.
And apparently cremation forms has come up before in an OSCE. It didn't come up in ours. They're really self-explanatory. They've got the same bit again about 1A, 1B, 1C and 2. In your OSCE, if you get it, you just need to fill it in as quickly as you can, because the hardest bit about it is how long it is. So other relevant bits that you need to know on a cremation form is exactly the same as the death certificate, the information you need. You just need to have said where it asks about if you've examined the patient, that you've done a full external examination, that you aren't worried that in this patient obviously you refer to the coroner, but normally you're not worried, you don't need to refer to the coroner.
And then there's like a box, and it's like a brief summary of what led to the patient's death. And I like always used to write loads of information, but you don't need that much. It's literally they came in, X, Y, and Z happened, and then they died. It's just so that the person that does the second part has something to go on, and they normally ring you anyway just to confirm. Yeah.
Okay. This is an aside now, not to do with this patient. Have you all got a Warfarin chart in front of you?
Yeah.
Yeah. Okay, so he's just write it up for the same patient, go with Harold Bishop. He's on warfarin for an AF, and he's normally on 4 milligrams a day. So if you can try and write up a warfarin chart.
I don't know about you guys, but when I was hitting it, warfarin charts like completely confused the life out of me. So basically, all you need to really do is, unless they've got like DVTs and PEs in the history, you can reload them if they're already on warfarin on the dose they were on when they first came into hospital, and just kind of do INR checks and refer to warfarin clinic. If they've had like PEs and DVTs in the past, then you follow the loading regime. So you can either do the 10 milligrams or the 5 milligrams, depending on, like if they've got any risk factors.
But you've got to, don't be too worried about it, because if they've come in on 4 milligrams, as long as they're not profusely bleeding or anything else, if it's just an aside, they will have been at home on that and not have noticed anything, and they will have just waited for the next Warfarin clinic appointment. So just start them on the 4 milligrams and do kind of every other day INRs. If you're not worried, kind of every couple of days is absolutely fine.
And you can normally start it if there's no bleeding risk a couple of days after surgery, and then you carry on with the enoxaparin or tins, and then when they're in the therapeutic range of the Warfarin, you can stop the tins and then they can just go home on the Warfarin.
So just to explain that bit again, so if people are either started on Warfarin, they need to be within their therapeutic range. So for this guy, his target INR is 2 to 3, but he won't get to that straight away. It'll be either higher or lower, probably lower. So what you need to do is you need to start them on treatment dose tinzaparin. So to work that out, you do 175 times their weight in kilograms. And you'll get a number, and that's the number of units. It can be massive because some of your patients are huge. You'll get a big number. So you give them that number of units with the Warfarin until they're in the therapeutic range.
And would you write that also on this yellow chart?
No, you write it on the drug chart.
Okay.
Yeah.
Okay. And again, like with the insulin, you'd write on the drug chart Warfarin, and then see on the chart. You know what I mean?
Okay.
Sorry, just to clarify, so we're going to start the tinzaparin anyway, and we're going to start the Warfarin. What dose Warfarin do we start?
So this is an aside. Don't think of the scenario now. Just think of him. So he's come in on 4 milligrams.
Oh, so that's fine.
Just start off.
And we don't need to give any tinzaparin, do we?
No, you do.
No, for him, you don't know. For this now, we're staying gently.
Don't you cover them?
I only send you the bridging dose when you're starting Warfarin.
Only if they're not within the therapeutic range.
Yeah, but once they're in therapeutic range,
Yeah.
then you stop.
Yeah.
No.
So he's come in on it, so you don't need to give him
Because
tinzaparin.
INR is
But if you were starting him on it in hospital,
Yeah.
you need to bridge it with tinzaparin. Yeah.
That makes sense.
Oh, okay.
Yeah, so the question in relation to that is what dose of Warfarin do you start them on?
You need to do the loading thing if you're starting them on it.
Do you know in this column, is it the target INR or what the last
What the
What the INR is that day.
Okay.
Yeah.
Your target INRs can stay the same. And then there'll always be advances on the board as well, so if you've got any questions, they'll tell you to different dose or to go down. So I wouldn't worry about it. It's just we thought they were quite
an old lady, whatever, coming in through checking that she's on regular Warfarin. And she's on regular Warfarin. She's went for something else, but she's on regular Warfarin. And would you write her up on here for her regular dose? Do you tell her to check her INR every day, even though she doesn't have it checked regularly?
I'd probably check it every other day. If you check it on that Thursday, you check it when she comes in, and if it's fine, then you can just check it every couple of days.
So they don't have to fill in that box to give her the dose?
No.
You can go by yesterday's or you don't
It's
have
more
to.
they box it off so you know when to check it, rather than you have to every day.
But you check it every day if it wasn't within the range, if it was too high or too low, if it was within doses or anything. Is that alright?
Yeah, if you're not completing them every day, then I'm with you.
Yeah.
So really sorry about the PowerPoint. But does anyone have any other questions? This is the end. Normally when my patients come in acutely, so I don't.
It's 3 to 5 days. Every single year, you will have to prescribe in your OSCE. Every single year that comes up. Okay? So you need to know how to prescribe a lot of stuff very well, so that you don't even hesitate when you're in your OSCE station. Nearly every single year, you have to prescribe blood and you have to prescribe fluid. So you also need to make sure that you can do that quickly and confidently. And also the blood form for when you take blood, because that is a common station. And you will And another form that comes up every year is promotion and death certificate, and they alternate. Last year it was the death certificate, the year before that it was the promotion form. So you're probably going to get, well, you could get one or the other this year. So these are all forms that are going to come up, and you need to be really familiar with them. So before you go into your OSCE, you go back to this PowerPoint. It will go on the website.
The user proper one, I'm so sorry, it didn't work.
With all of the pictures, and just make sure you know how to do it all properly.
Yeah, the main thing is just practice. Like, that's what we did before. I just get as much as you can, just go and see it from the wards. If you go one by one, it's fine. And just keep practicing. Write scenarios up for yourself. Look on Ask Dr. Clark and get all those past scenarios from different years. And just, you can go through them really quickly. Like, I think by the end of it, I've literally gone through every single year, every single station, and they will come up, that's the thing. I don't think I was massively thrown by that many last year because we practiced them, and because they've come up in previous years. So as long as you keep practicing and keep calm and exam, you'll be fine.
They don't want to fail you, they really don't. It's just being safe, and if you're not sure, just say you're not sure, and don't feel pressured to write anything.
You all have loads of paper on your desk. Please fill out the feedback form, though. Please do not leave without filling out the feedback form. Thank you.
What do you mean?
All right.